We add night to it. So sometimes we mention that it's night bedwetting, but all that it means is that the person wets when they fall asleep. It doesn't matter whether it's in the night or the day. So this picture is showing a child who has wet and is looking so sad and dejected. You can tell from his face that he's unhappy about what has happened. So we just look at this will be the outline, just for us to know what this term is about. There are two main types of wetting. There are children who wet when they sleep, and that is the only problem. And there are children who wet when they are awake and also when they are asleep. So those are the two major types of wetting or enuresis that we have. Those who wet when they are asleep, and those who wet when they are awake and when they are asleep. But all these people do not wet continuously. Hence the term intermittent and continuous means that you are not able to keep your urine and the urine just comes out. Incontinence just means that urine is coming out involuntarily. So it's not under the control of the person who is having that problem. It can even happen in adults as well as children. This group refers to people who are always wet, and that is a more serious condition. And that's not what we are going to look at this evening. We are concerned about those who wet intermittently. So it comes when they are asleep or comes when they are awake. And for those who wet when they are awake, it's also most of the time associated with other problems. So we just concentrate on those who wet usually when they are asleep. And that's what constitutes the bulk of bedwetting in children. So the bulk of children who wet are those who wet who are asleep. And those are the ones that we'll look at this evening. So for those who wet when they are asleep, there are some children that the mothers will realize that that is the only problem they have. Aside wetting their bed, passing urine involuntarily when they are asleep, they are fine. But there are another group of children, there's another group of children who, in addition to wetting their beds when they are asleep, also have issues during the daytime. So some mothers on the platform who might have noticed that some of these children would pass urine at short intervals during even the daytime. Or when they have to go to the loo, they have to rush, otherwise they wet themselves. So that group fall under this arm here with that big name, non-monosymptomatic. Mono means one. So once it is not one, it means that they have other symptoms aside the wetting when they are asleep. And this arm here is mono. Mono means one. So monosymptomatic. These children just wet when they are asleep. When they are awake, they have normal urination habits, no rushing to the washroom, no short intervals between eating or visiting the washroom. So they have monosymptomatic. Those who have other issues are non-monosymptomatic, and they usually have more problems as compared to this group. But for both groups, we further classify them into children who have never been dry. That is, they have never had any period more than 6 months where they sleep and do not wet their beds. So if you have a child who, since they were infants, have been wetting till 10 years, and the periods that they are dry does not exceed 6 months, we term them as having primary monosymptomatic enuresis. But if you have a child or your child was dry for about a year and starts wetting when they are asleep, then they have secondary enuresis. And for this category of bedwetters, they might have associated social problem, sometimes even change of school when they are not happy about the school they are in, or when they are unhappy about family situations, parents quarreling, divorces, they can have these secondary enuresis. But for those who are primary, Usually, a lot of them have no other associated symptoms, and they are easy to manage and they grow out of it. So for any child who fall into this category of secondary enuresis, we want to probe and probe till we find an associated cause for that problem. So how common is this problem, enuresis? It is quite common. Even though, as I say with most of my presentations, it's not a condition that is going to make a mother or a father rush to the emergency room. It is very common. And it has a lot of psychological consequences on the children that they affect. Even though it's not going to cause any medical emergency or complication, when it comes to the social impact and the psychological impact on the children, it is very, very dire and far-reaching. When we take children who are 6 years of age and below, around 6 years, about 10% of them would wet when they sleep. We realize that you can see from the pyramid here that as they grow older, the proportion or the prevalence becomes smaller. So it's typically a problem of younger children. But if you have a child who is less than 5 years of age, wetting their bed when they sleep, it is considered as normal, in quotes, because their developmental age allows them to wet when they sleep. But any child who is 5 years and above who wets, then that is classified as enuresis. Anytime below this age is considered a normal physiological issue. So it is not termed enuresis. We have a small proportion in teenagers, about 0.5% to 1% of teenagers will wet. But I think with time, especially if we are able to collect some data in our part of we'll see that this number, unfortunately, is increasing. This number, unfortunately, is increasing. So the figures might change with time. But generally, we should know that the younger the child, the more likely they would wet their bed when they sleep. And the older the child, the less likely they would. So what causes enuresis, or what makes a child wet when they sleep compared to adults? I'm told that there are few adults who wet, but generally we know that adults do not wet their beds when they sleep. So bedwetting is a well-studied topic. So sometimes parents come and they think that, oh, this one is somebody, as the local parlance will go, my 18-year-old child wetting somebody who is doing the child. It's not somebody who is doing the child. They are well-studied, understood principles or ways why children wet their sleep. There's something called nocturnal polyuria. So usually when we sleep in the night, the body has a mechanism that makes us produce less urine in the night compared to the daytime or when we sleep. But in these children, this mechanism is slightly dysfunctional or doesn't work as it's supposed to. So they still produce a lot of urine even when they sleep. And that makes them wet their beds. The second is what we term sleep disordered arousal. So we have come to know that children who wet their bed, and even some mothers would have found that for their children who wet when they sleep, they are very difficult to arouse from sleep. They are deep sleepers. So actually what it is that these children have problems sleeping. So the body has also set their arousal mechanism to a high threshold, so such that when they fall asleep, it's difficult to wake them up. So that is what is termed the sleep disordered arousal. So it is because they have problems sleeping. So the waking thermostat have a higher level by the body, so that it's difficult to wake them up. And once you have sleep and you are asleep and you've produced urine and you have to wake up to go and pass urine and you are difficult to be aroused, the next thing is that you wet. But if your bladder, that's where the urine is kept, is full, and you're able to wake up to pass urine, then you don't wet. You just wet in the night. The third thing is real problems with the bladder, and bladder is stored. So all these, you realize that it's not directly related to the bladder. But this third problem in children who were considered bladder dysfunction is an actual problem with where the urine is stored. So one, some children are born with very small bladders. So the capacity of the bladder is small. So it stands to reason that if you have a small container to keep urine and I have a bigger one, your own will get fuller than mine. So if you have a child whose bladder capacity is very small, the wet compared to someone who has a big one or a normal one. Some children also have problems with their urination pattern. The very function of their bladder is dysfunctional. There's a tight closure at the end of the bladder, which is called the sphincter, which is supposed to open and let urine come out. And then the muscles in the bladder are supposed to push the urine out or contract. For some children, this mechanism is a problem. It doesn't come to them easily. So the bladder contracting and the tight sphincter opening are always fighting. So instead of the tight exit of urine to open, it also fights against the bladder. And in the process, they manage to get some urine out, but then there's some kept there. So their bladders are always full. And these children will also wet. There are other problems with their bladder that will also make children wet. So these are the three main mechanisms. Children who produce a lot of urine in the night, children who are difficult to awake, and those who have real problems with their bladder. So this is just a cartoon representation of what I've spoken about. If you are awake and your bladder is full, and you're able to, if you are asleep and your bladder is full, but you're able to wake up, then you just pass urine. And that is called nocturia. If you're not able to pass urine and you're deeply asleep, then you wet yourself because the bladder has to come out. So even though these are main pathways by which children wet, there are other contributory factors to children wet. We know that this runs in families, even though a lot of parents will not own up and tell you. If you talk to them privately, they'll confide in you and let you know that I was wetting till I was 15 or 16. So this runs in families. We know that bedwetting runs in families. And as I mentioned, the younger the age, the more likely the child will wet. It has also been found that the male's sex is a risk factor for bedwetting and then black race as well. If you have a child, as I mentioned, so those who have urinary tract infection can also wet. And this is very common in those who were not wetting for about 2 or 3 years and they start wetting. This is one problem that we tend to look out for, to make sure that this child is not wetting because they have urinary tract infection. Then we have those who have other stresses. So I've had people whose parents fight or they're unhappy, they've moved from a school and they start wetting. So emotional stress can cause children to wet. Children who have attention deficit hyperactive disorder can also wet. So some children come and the parents will even tell you that this child cannot even sit for a minute. So the same way the whole body is hyperactive, their bladders are also hyperactive and want to get urine out of them, and they also wet. Constipation is a very common association with bedwetting. Where the bladder is located, that is, the bladder is where the urine is stored, and where feces are stored, they are next door neighbors. So if the rectum is always full or loaded with stools, it takes some of the space of the bladder. So the functional storage space or capacity of the bladder is restricted and is limited. So the urine capacity is reduced. So the small amount of urine that goes to that small space that is left, the bladder is full and has to come out. So constipation is a very, very important contributory factor to children wetting in the night. Then children who have big tonsils or adenoids. So some parents will realize that you are told that your child has adenoid hypertrophy, or the tonsils are big and in the night they snore. All this works through the pathway of poor sleep. So children who are obstructed when they sleep, they don't have good sleep pattern. So when they sleep, they are also likely to have the problem with the arousal mechanism, because their body also naturally sets the arousal to a higher level. So it's difficult to wake these children up. These children in this category, those who have chronic kidney disease, diabetes, sickle cell, they are not able to concentrate their urine. So they produce a lot of urine, which is very dilute urine in these three groups of children here. And they also are likely to wet. So these are some of the things that will contribute to a child working. It's not exhaustive, but then these are common associations with children who wet their bed. So how do we help children who wet their bed? So once in a part of them, once you have a parent bringing their child to see you that they wet, it means that it's a problem for them and it's a problem for the child, because typically they will not come to the hospital. Because as we all know, these children will go out of it. So they'll go out. So once a parent comes with a child who is wet, it means it's a bother to them. And once it's a bother to them, we are even happy because they're able to manage the children well. So how do we help parents when they come to us? Oh, I know we have some parents also on. So how do we help their children who wet the bed? The first thing, and which is very important, is to create a very good relationship with both the parents, the child, so that it's an open discussion, nothing is hidden from you, so that we're able to help the child come out of this problem. And it's important, the second thing I put here is that we need to have a motivated parent and child. Because if you don't have a parent who is motivated, or a child who is very motivated to stop this habit or this, developmental problem, it will not happen. Because as you know, and I'll show in the next few slides, it is a lot of behavioral change or psychological therapy, as opposed to medications or just giving medication to treat this problem. So if you have a child who is not bothered about wetting their bed, you need to postpone the management and let them go and come at another time. But there's no way this child is going to comply with all the things that you tell them to do. Or a parent who is also not too bothered about the child wetting, it will be a good time to start the management or helping the child come out of this. So this is very important. These 2 points are very, very important. So we would ask questions. All the things that I've spoken to you about, we would find out whether your child also has any of those things, because the patient family will do that. First of all, we want to know your child's age. If your child is 3 years, sometimes we have parents coming to, my child is 4 years, he's wetting, we are not, I'll let you go and come back. The child is much older. So not much older doesn't mean like 10 years, 12 years, but even when once the child is above 5, we can start something. But if the child is less than 5, we don't worry so much about it, because it's allowed. It's allowed in that stage. And then, as I said, we want to know whether the child has been dry for any period that is more than 6 months, because that also helps us in how to manage these children. And also find out whether the child has been tried on anything previously, so that we know where to take off from. Then another important thing we would ask you when you come with your child who is wetting or having enuresis is the frequency of wetting is very, very important. If you have a child who is wetting once in a month, as opposed to a child who is wetting almost every night, the management will be fairly different. And our concerns and worries will be different from these 2 children. So it's very important, because the more the frequency, the higher the likelihood that this child is going to take a long time to come out of the problem. Then we also would ask the parent, what time does your child wet? Is it when the child sleeps immediately, like the first few hours, or is later getting to the morning? It's very important, because it helps us fashion out the management plan for these children. If you have a child, your child is wetting as soon as some parents will say, look, even an hour into the sleep, they'll wet. you can tell that this child is producing a lot of urine, or this child has a very small bladder, so he's not able to store much urine, as compared to a child who is wetting close to the early hours of the morning and hasn't wet the whole night. That it has even a better prognosis. Then we would also find out that when your child wakes up, despite passing urine in the night, does the child still have a large volume in the morning? It also points to a child who is producing a lot of urine in the night. And most of the time for these children, we would add some medication to the children. Then this point here, what are the child's daytime drinking habits? Also another key point to find out, because it starts to reason again that the more water you drink, the more urine you make. The less water you drink, the less urine you make. So if your child is drinking a lot of water during the day, and especially close to their bedtime, they would wet. So sometimes you can work on this, and it helps decrease the frequency of wetting when they sleep. So we would advise that children shouldn't wait and drink water the last half of the day before they sleep. They will not have time to pee all this out, and then they'll pass urine in the night. Other comorbidities, so I mean the other conditions in addition to bedwetting that the children have. Does your child have daytime symptoms? Daytime symptoms mean any other symptoms. So some of them include a child who is peeing almost a short interval. We call that frequency. A child who cannot keep urine at all, they need to rush to the washroom. It is called urgency. A child who goes to the washroom and has to strain before the urine comes out is called straining. A child who cannot, especially males, who cannot pee in one stream and has to drop, it comes a little bit and stops, a little bit and stops, is called dribbling. And that often needs to be managed even before the bedwetting, or the causes of these need to be investigated for before we manage the bedwetting. Does your child have pain when they pass urine? That is what is called dysuria. If your child has pain when they pass urine, it might signify a urinary tract infection. Is your child constipated? As for that is very key, and I always ask that. Or does your child have any behavioral problems like attention deficit hyperactive disorder, any learning difficulties or mental challenges? It could also be associated with bedwetting. If your child is drinking a lot of water, the child will wet. Or passing a lot of urine, drinking a lot of water, weight loss, some of these things can point to more serious diseases like diabetes and even kidney disease. Or whether your child snores in the night. When the child snores, as I said, they have sleeping problems, and these sleeping problems can make them difficult to be aroused and make them wet. So, and then, even though I put it last year, it is very, very important. Psychosocial concerns. Is your child happy at school? Is anybody bullying them at school? Have you changed schools and the child is struggling to settle? Do they have problems, any social issues in the house? Are parents, going through a hard time? So any social problem can make a child wet their bed when they sleep. And especially, as I keep underscoring, for those who have been dry for even years and they start wetting, or even children who have been abused, so that's sexual abuse, physical abuse, psychological abuse, and they can have problems with enuresis. Good. So when you come with your child who is wetting, or for us, if they are health workers with us, if you are presented with a child who is having enuresis, aside your history, you need to examine the child. What might you find when you examine the child? So typically, and especially for those who have never been dry since birth, you might not find anything on examination. You might have you have a full normal examination with the child, head to toe. You will not find anything wrong with the child, because a lot of the time, in some of these reasons that I've mentioned earlier on, so physically, you will not find any problem with the child. But for those who have the secondary enuresis, for those who were dry for some time and now are wetting, you might find some problems with this child. Or for the very first group that I never even dwelt on, for those who are always wetting, they might have problems with their spine and all. So if you are a health worker and you have a child who is passing urine, who is wetting when they sleep, you need to do a thorough examination, full examination. So I've summarized some of them here. Usually we'll take the height of the child, we'll take the weight of the child. As I mentioned, more serious diseases that might be associated with bedwetting, like diabetes. And these children might be underweight or overweight, so you need to check it. We might look into the child's throat to check and make sure that the tonsils are not enlarged, because that can also be a contributory factor to the child's bedwetting. We look at the abdomen, see whether the child has hard stools, is constipated. We're able to find that. Or sometimes we actually do ultrasounds to find out whether the stools are really, the rectum is filled with stools. Then we need to look at the genitals. So it's important to do a thorough physical examination. Even though I have mentioned that typically everything is normal on physical examination, you need to check before you make a negative, you determine the examination as a negative one. You need to examine. Then it's important to look at their back, because children who have problems with their spines have problems with their bladders, because these nerves are going to supply the bladder. So I've put all these examples here, especially for those who have secondary enuresis. Then sometimes we move on to what we call the bladder diary, using the bladder diary to help identify the type of problem, the type of cause that's the cause of the enuresis of the child. This here is a very simple sheet of paper. You have time here, and you have what your child drinks and whether they void how much they pass. We can forget about this. Some children have other problems. As I mentioned, they have urgency. Some even wet on themselves when they are awake. So that is a more complicated issue. But for those who do not have any of these, all we want to know is that how much is your child drinking? You need to measure it. And then, unfortunately, you need to also measure how much your child is passing in terms of urine, is passing out. And very important, when your child wakes up, we want to know how much your child also passes. It helps us to see whether your child has a small bladder capacity, whether your child has a big one or a normal one. It also helps us know whether your child is producing too much urine in the night when they sleep, and we fashion our treatment for that. So this is called the bladder diary. Sometimes, especially for those we suspect have medical problems, we look at the urine, we do urinalysis. So it's a simple urine test to make sure that it's not a urinary tract infection that the child has. And a few of the children, we might do an ultrasound of the kidney, the bladder, and so on. And so these are more complicated and more sophisticated examination. And typically, we don't even get to do these in the bulk of children who wet their bed when they sleep. So the basic will be a urine test, and then at best an ultrasound. But if we find anything on the ultrasound, then we might advance the imaging to involve the MRI and the other studies that are shown there. So we definitely have ways to help children who are wetting their beds. So it is nothing that is so difficult to handle. And the good news is that even without these approaches, a lot of children, in fact, most children will go out of bed. But just that lately, we are seeing a lot of children who are wetting into their late teens, and it's quite worrisome on them because psychologically they are affected, their self-esteem is affected, their confidence is shaken. So we don't want that. So that's the reason why sometimes we want to institute these measures before they get into their late. So key here, we want to educate the parents on the condition. So those are some of the primary or early statements I tell parents that this is a condition that most children grow out of it, but we don't want it to affect them psychologically. So that's why we want to intervene before. And I reassure them. So parents who have children who are having bedwetting should be reassured that they will grow out of it. Then if there are any other comorbidities, as we call them, we try and manage them first. Because sometimes when you manage these comorbidities, the bedwetting even resolves on its own. So constipation is number one. If you have a child who is constipated, that should be dealt with thoroughly and free that area where the bladder is, so that there will be enough room for the urine to stay before it comes out. And some of the children, once you address constipation, the enuresis or bedwetting resolves. So the problem becomes abated. If you have a child who has obstructive sleep apnea from the huge tonsils that we know about, adenoid tonsillar hypertrophy, this we usually will refer to the surgeons to take the tonsils out and help us manage the enuresis. Or any other psychological, behavioral, or psychiatric disorder, we need to manage these first. After managing these, then we look at the behavioral interventions. So it's just a few children that our first line of treatment will be medications. We hardly do that first. Even for those that do medications, we will try these things out before we put them on treatment. So one, you need to limit the fluid that a child takes. It is very, very important, because as the more the child drinks, the more they will wet. So at least 1 to 1.5 hours before bedtime, they shouldn't take in any food or drink. So if your child sleeps around 8 o'clock, at least latest by 6:30, they shouldn't be drinking or eating. I know some children will sneak and go and eat. So that is why you even need a very motivated child before embarking on any therapy for a child who is wetting when they sleep. Because otherwise you don't get their cooperation, and it's frustrating to parents. But it's because the child is simply not motivated to stop. But if you have a child who is motivated, they'll cooperate and comply with these therapies. The next thing is sometimes physically waking the child up in the night to go and pee, especially for those who are younger. If you have a 6-7-year-old child who is wet, you can physically raise the child up lift the child, wake the child up to go and sleep, to go and pass urine. So when you wake the child up, they go and pass urine intermittently in the night. Or if they are small to be lifted, you can also do that. And then I'll jump this and come to this, the reward system. It is very, very important. So far, you realize that I haven't mentioned punishment for these children, because already some of them have very low self-esteem and confidence. We do want to desist from negative reinforcement. We want to do more of positive reinforcement. So if you have a child, you know what your child likes. So I could start chatting, but in an environment, I don't know how many children will be excited about having stars. So you know what your child likes. You should try and reward the child accordingly. So you agree with your child that if you go a certain number of, even if you start with 2 days dry night, depending on how early the child went, it will motivate the child as opposed to punishing the child. So punishments we should desist from, because after all, what they will say that after all is my mother will just spank me and I'm used to it. So that doesn't help them. But when we reward them, it's a major driving factor to help them stop wetting when they sleep. Then bladder training. So simply what this means is that when you have a child who is wetting and having frequency, especially those who are wetting at short intervals, who are peeing at short intervals, during the daytime when they want to go to the washroom, you can delay them a bit, but you don't want to delay them unduly too, because that is also a risk factor for urinary tract infection. So you just want to train their bladder a little. So if you delay them about 5-10 minutes before they go and pass urine, it helps they train their bladder so that they're able to keep urine for longer periods without wetting. Then we have overlearning. They're all different. They're all behavioral therapies. So when a child is able to be dry, maintain a dry bed for about 14 days, you can let them drink an extra, or even reward them extra. That is the overlearning. And then cleanliness training. It is not punishment, but this is how it works. If your child wets, they need to change their beddings themselves. So they need to change their beddings. If it's an older child, they need to even wash it themselves. It is not a punishment. It is a form, it's a form of training to help them resist from passing urine in the night. So this one is allowed, but it's not punishment. It's called cleanliness training. This is different from punishing a child by spanking, lashing, screaming out, making the child cry and all that. So this is different from punishment. It's cleanliness training. The child should change their beddings. If they are young and they cannot wash, they can remove them and put it where it's supposed to be washed. So that, so it all deters them from wanting to wet, or deters them from wetting when they sleep. So negative consequences for wetting should be avoided. I have emphasized that one enough. We should not do that. Some traditional means of dealing with children who wet, it's you can't even mention it on this platform. Terrible, putting pepper in all sorts of wrong places. So we shouldn't do that. We should desist from that. So aside these behavioral interventions, what are some of the key ways that we are able to manage or treat children who wet, who we know who need to stop wetting, especially for those who are in their teenagers, those who are going to boarding houses, those who are having real psychological issues because they are wetting? So one is the use of the bed alarm therapy. So bed alarm therapy is the gold standard for management of children who wet. That is what has been tried and tested and has been known to have a remission period, or a period where children remain dry for a long time, as compared to even the drugs. So bed alarm is important because it keeps children from wetting for a longer period of time, even compared to the medication. So these are special alarms. They are not the alarms that we have on our phones or the alarm clocks that we have. So some parents go and get these alarms and they come and say that it is not working. I'm using it, but she's still wetting. So these alarms are they are very fanciful, very colorful ones. So they come with the main alarm system and an electrode with a pad or a pad. So you put the pad under the beddings or in the pants of the child. And as soon as the child starts wetting, the alarm goes off. And it's quite loud. I have a few. They are so loud, the child will wake up and go and pass urine. So some parents get a bit, confused and, because I came to you that I want my child to stop wetting. And this alarm that is so good is making my child wet before the child goes to pass urine. But it works on the mind, and it's called the operant conditioning. So after about at least 14 days or 2 weeks, the child will start going to pee at the time that the alarm usually goes off, without the alarm going off. So that's how it goes. It works. And usually we really need to encourage parents and let them know that it's not like medications that you take and you get an instant result. You need to be committed and be patient for some time. And even some, we try in 3 months before they see the results. But it's the one that has the longest lasting effects on children who wet. So I'll go over it. There's an electrode or pad. As soon as urine comes into contact with, or as soon as the child wets, the alarm goes off. And it's so loud that the child needs to get up and go and complete the wetting. And with time, the child will wake up on their own to go and pass urine, even without the alarm going off. And then these are the drugs that we use. There's one here called desmopressin. So this is a medication that helps us reduce the amount of urine that we produce when we sleep. So I mentioned that normally the body naturally produces a hormone. So this is the synthetic form of it. So we are giving that hormone that the child is lacking in a way, so that the child is able to produce less amounts of urine in the night. These here are called anticholinergics. They are for children who have what we call hyperactive bladders. I mentioned that children who have attention deficit hyperactive disorders can also have hyperactive bladder. Just like they're hyperactive, their bladders are also hyperactive. So these medications here quieting the bladder a bit where the urine is stored so that they don't pass urine frequently. And these will also help with other psychiatric and psychological problems that make the children pass urine. And then I've put here combination. You can have a combination of these. You can allow child use the desmopressin for the child anticholinergic. So some parents will realize that we do alarm therapy and we also add medications to it. But the first line after the behavioral therapy is alarm therapy. Unless you have a child, you can tell it's clearly wetting because they are producing a lot of urine. Then after the behavioral therapy, we can straight away do medications for these children. So this is just a summary of what we do for these children who are wetting. Counseling and education is very important. I mentioned assessing the motivation of both parent and child, because if they are not motivated, there's no way this child is not going to drink before they sleep. They will drink, they will eat, So you need a child who is motivated. I've mentioned that the bed alarm is the most effective, and then we can do combination for these children. For children who have other problems aside just the wetting, these are some of the few of those problems. This is called an overactive bladder. And this is a child who has dysfunctional void. So I mentioned that some children passing urine is not a simple task. It's difficult for their whole system to pass urine. So the end of the bladder and the bladder itself are always in constant, fight, for want of a better word. So it's called bladder sphincter dyssynergy, or they are fighting. They don't cooperate with each other. So those are called dysfunctional voiders. And these children always have in their bladder and they tend to wet. So for these children, we do a lot more than those who just have bedwetting as their problem. We have what we call urotherapy. So urotherapy simply means that trying to get the bladder function under the control of the mind. So they are more complex. So sometimes we train the child on how to use the pelvic floor to coordinate passage of urine. We'll tell the child how to sit on the washroom. So one simple urotherapy method is to let your child turn their front to the water closet, the bowl. So typically we all sit with our back towards it, but this child will turn around, and that opens up the pelvic floor and helps especially children who are dysfunctional voiders. So a few of the children that we know have this problem, we have urotherapy for them. And sometimes, as I said, we do more complex things. We're not going to that, called neuromodulation, trying to get the bladder's function under the control of the child's mind. But these are more technical issues that we do. So in conclusion, bedwetting or enuresis, I know, is a source of frustration, especially to the older child, and disappointment, especially when they wet after a long period. Sometimes they just out of it. 3 months I haven't wet, and then they wet. They get very disappointed, but they need to be encouraged and need to be, spurred on to continue these therapies that we start them on. As I put here, treatment and assessment should be directed towards underlying contributors. Some of them, once you address these underlying problems, the wetting stops. And sometimes we combine therapies for these children. But for those of us who are health workers here, we really need to be empathic and then inform ourselves about the ways to manage these children. And all these will contribute to the success rates of children who have enuresis. So thank you very much. It's been a technically challenging one, but we've been able to do something.
Oh.
So thank you very much for questions.
Thank you. Thank you so much, Dr. Nyann.
Welcome.
It's been a very excellent presentation there, in spite of our technical challenges.
Challenges.
So I have comments here. Thank
Okay.
you. Wonderful presentation. Thank you so much, Beatrice. I'm glad that I stayed for the presentation. Okay, but I have a few questions. So the first one is two questions. They're about the same. That why is it that there's an increased prevalence in enuresis and also increased prevalence in the teenage prevalence? Is there a particular reason why you're seeing more these days?
Yeah. So thanks for that. It's an interesting question. We are yet to do our own studies and find out why.
Okay.
But so generally, attaining bladder control used to be high in the Western world. And people in the low resource countries were proud to say that, oh, we have fewer number of children who attain birth control, like to attain a bladder control. But with our current, so now we are also becoming very modernized. We are using diapers that we didn't used to use before. So our children, even now, even before the age that you say a child is an enuretic, are now attaining bladder control as an older age. Now we are becoming more modernized. Children who are as old as 4 are even in diapers. They are not motivated to even go. Yes. So some time back, we had very good bladder, 2 years, children have very good bladder control. But now we are having, even though I say we haven't done studies in our environment, but now we are having similar patterns like the developed countries. So all over the world, I think Australia has the highest rate of enuresis. And I think, even though I'll still say that we haven't done studies, this is anecdotal, and that is what but we haven't done studies to confirm them. But it has a lot to do with how we are training these children in terms of their bladder control. So they are attaining bladder control very, very late. And our social structure is also changing. We are having children, I didn't go into all those, the other things that can help children also not keep their bladder full and then wet, especially for those who have daytime wetting. Children are spending a lot more time on their screens. They are keeping urine more. So some even wet both daytime and wet nighttime. So I think it has a lot to do with our social, structure that is changing. So now we are becoming more like the developed countries and having these. So generally, our children are not attaining bladder control early. So generally, aside all those psychological issues that some teenagers have, some are having other things, social issues that is making them wet. But generally, the way we are training our children in their bladder controls, I think has an effect on that.
I see.
Plus with the teenagers who are wetting, I think it's more psychological issue. But as I said, this is all anecdotal. I don't have evidence yet to prove to speak to that.
Thank you. Thank you very much.
Okay.
Somebody wants to know where they can get the alarm, the bedwetting alarm.
The bedwetting alarm. So it's been difficult to get because, and knowing to me, I thought I was prescribing alarms for people to get, and I thought I prescribed the right place, but they were not getting it. But now there's a nurse in Rich Hospital, but maybe after the presentation, I can share the contact. Marley, can I share with you?
Yes, please share with me.
So I can share with you, and then you can.
Okay.
Or I should. There's a nurse in Rich Hospital. I think you can get some from. She's on the pediatric ward. Yes.
Okay. All right.
There's a nurse, and yes. So I'll share her contact with you.
Okay. Thank you.
Yes.
All right.
Yes.
Okay. Then somebody said they bought, I don't know if they were prescribed or they bought it themselves. They bought desmopressin for their child or their ward, but it was expensive, so they couldn't continue. They couldn't continue. I'm not sure.
Interesting.
Would you usually prescribe desmopressin alone without the other stuff? Okay.
Exactly. So I see I see a lot. So I'm going to do one even for general practitioners and doctors especially. So it's not a drug to be used as first line unless you have investigated, especially with the bladder diary. Sometimes we do what we call uroflow studies to see that this child is producing a lot of urine, is lacking that hormone I mentioned, that there's the ADH.
Yeah.
So it's not a medication that we should just prescribe. And we prescribe it cautiously because it also has significant side effects. And before we put any parent, any child on, we need to educate the parents on it because this medicine is making you keep water and preventing you from producing a lot of urine. So you need to limit the amount of water you also drink because otherwise then it has serious consequences. So sometimes I tell some of the doctors that we should desist from prescribing desmopressin as first line. We should desist from it and we shouldn't be using it alone unless you have a child that no, this is nocturnal polyuria, and then you do. But it's a small dose that we do. And I hope we are doing the right doses. So typically we don't do it alone. It's usually in combination with the alarm. There's a new brand. Anyway, I can't advertise it here, but there's a new brand on the market that is reasonable. That is reasonable. Yes.
Okay.
I can share that with you later too.
Okay. All right.
There's a new brand that is reasonable. Yes.
Okay.
Yes.
Okay.
Yeah.
Our next question says, thanks, doctor. Please, how do you help a child with a small bladder who wets bed within the first hour of sleep and uses the washroom about 6 times within 1 hour during the day?
1 hour during the day. Oh,
and the child also drinks a lot of water.
Okay. So we'll start from the back. So as for the drinking a lot of water, fine, it's good. But you shouldn't let the child drink close to bedtime or push all their water drinking, because some of these children are very smart because they know when they are in school, sometimes it's difficult to get permission to go and pee, and they'll leave, or when they come, they drink water. So we should try and get the child not to be drinking so much close to bedtime, because water is good. They can drink water, but not so much close to when they go and sleep, at least an hour to an hour and a half, so that the kidneys will make urine and the urine will come out. For children with small bladder capacity, so we measure it. So some of these children, I actually will let them do an ultrasound so that I confirm it and make sure that their bladder capacity is small. And then using the bladder diary, what they pee, the first one that comes out. Also, it's an estimate of how much. So we need to confirm first that indeed this child has a small bladder capacity. So for these children who have small bladder capacities, we sometimes, but we are not going to put a child who has enuresis on that. Sometimes children who have other problems, we actually augment. Surgeries can be done to fashion out, to make the bladder a bit bigger. But typically, these children have other serious issues. If it's just wetting, we will not go and augment the bladder and make it bigger. We will manage it with a behavioral therapy. So these children will benefit from alarm therapy. They will benefit from reduction of fluid intake before they go and sleep, even though we cannot augment the bladder. But we will not send a child who just has wetting as a problem for bladder augmentation. That child should have more issues or have kidney failure, bladder is small, then that one we will augment the bladder. But there's room to augment the bladder surgically and make it bigger.
Okay.
Will such
a child benefit from the bladder training during the
day? Sure.
Okay.
That child will also benefit. So most of the behavioral therapies, that child, and bladder training will be very good for that child.
Okay. All right.
Yes.
Excellent. So this one is not a question, but I think a comment about the kind of psychological trauma some of these individuals face. So Latifa says, great presentation. Growing up, I witnessed a cousin of mine go through so much due to bedwetting. This affected her self-esteem and confidence, as she was constantly shamed and paraded through the neighborhood with her mat and urine-soaked outfit. Sometimes our grandmother would release a live frog on her during the night time. She was beaten a lot, and all through her early adolescence, she could not mingle with her peers. It's really sad how some of our people handle this. Yeah.
This is really sad. That's so, traditionally, I haven't heard these. I know about the pepper douche, but this one is quite, oh, this is too much.
Yeah.
So it's the psychological consequences on them is dire and far reaching.
Yeah.
We want confident adults in future. We don't want children whose self-esteem is just destroyed because of bedwetting. So we should so now, as we have heard it, we should let our old folks know that we've moved away from those negative reinforcements. It is not good at all. It leaves a lot to be desired. Yes.
Okay. Hey, we have plenty of questions, so let's continue. So the next question is that how do you help a child who wets herself both day and night? I think you've answered this already, but if you say something about it.
Yes, so both day and night.
Yeah.
So if a child sleeps during the day and they wet, and she sleeps during the night and the person wets, it's the same. It's considered the same. So the same.
Okay.
But we have children who wet when they are awake. They are playing, then they wet.
Yeah.
So those ones are the non-monosymptomatic, it's part of the non-monosymptomatic. And those ones likely have real problems with their bladders. So an example is the overactive bladders. So those children, they are awake, but they wet themselves. They have incontinence. So you need to tackle the wetting when they are. So I don't know whether that's what the person means. Or you mean that when they sleep in the day and then when they sleep in the night, it's the same.
Yeah.
Once it's related to sleep, it's the same, and we manage them the same. But for those who wet when they are awake and when they are asleep, those are more complex. So those are the ones that we might do the urotherapy, do the medication for, and handle all the other problems, the neuromodulation, etc., etc.
Okay. Right.
So those ones have real issues. They might be dysfunctional bladders, they might be active bladders. Yes.
Yeah. Okay. So I mean, for that person, Amanda, if this child is above 5 and especially older, I think you should go see Dr. Nyann so that you can get a proper evaluation and see what.
Yes, if they are wetting when they are awake.
Yeah, what's the reason why this is happening? Does enuresis have a genetic association? That's the question.
That's the question. So also interesting. So even though, currently I haven't read any gene that has been mapped onto, like we have an enuretic gene. I haven't read anywhere, but we know for sure that it runs in families. So maybe in the future, we might actually map a gene.
Find it out.
Exactly. But it runs in families. So definitely there has to be some gene, but we haven't we haven't found the gene, but it runs in families. Yeah.
Okay.
Yeah.
And the next question is, a girl of 12 years with enuresis, what do you think will benefit her? I think that's the whole presentation. 12 years with
as for that, around that age, you want to be more proactive and manage them, alarm therapy, behavioral therapy, all the things you said. So these are the ones that because they will be motivated. At 12 years, they'll be motivated. Yes.
Yeah.
We can go through what, yes.
Okay, so Red Lydia, behavioral therapy, alarm therapy, go see the pediatric nephrologist for proper evaluation. Thanks so much for the presentation. Please, my question is that I have a 10-year-old who used to wet the bed every night, but currently has reduced to once in 3 weeks or once a month. Should I worry about it?
So that is good. It just corroborates what I've been saying, that they will grow out of it. So you see, even with yours, the frequency is decreasing. And it's very true for children who have only bedwetting as their problem. So you practice those behavioral therapies. So decrease fluid intake, food 1 hour or 2 hours before bedtime, and try and carry the child 3 weeks and motivate the child. So you can practice any of those, but the child is likely to come out of it soon.
Yeah. Okay.
So this child not actively put on an alarm. Alarm will work for those who are frequent wetters. Exactly.
Okay.
So the child will come out, but do a lot more of the behavioral interventions.
Okay, all right. A 13-year-old boy with ASD, autism, who pees on himself not just at night, but during the day also. He stopped about a month ago and has started again. He knows when the washroom is and is able to say when he wants to pee. And parents have done a series of tests and the results are normal. Please, what could be the problem? I've actually encountered this a number of times.
So usually we know that those who have those conditions, so I just mentioned ADHD, but even those on the autistic spectrum and all that, it all has associations with enuresis.
Yeah.
All parts of the developmental issues.
Yeah.
So, I mean, so it will pretty much follow what I have said. If the child is older, but that one you might need more help. Dr. Mabel can also help with that from the autistic side management. But generally the same thing. We will try the alarm therapy for that person, but they might be more challenging because getting cooperation too from them might be difficult. But it's well known that behavioral dysfunction, psychiatric problems, psychological problems are associated. So it is not uncommon to find a child who is on the spectrum having enuresis. So it will follow pretty much the same thing. Try and decrease fluid intake to bedtime. Try and lift. If the child is younger, you lift, you wake, all those things. Similar thing. Yeah.
The few I've had with developmental issues who were doing this, it was a habit. So some of them were doing it because they wanted to change. Others were doing it because they somehow like the wet feeling of the on them, and some were doing it because they were stressed. So for for the one asking about it, you may need a behavioral assessment to see exactly what the trigger is.
Multidisciplinary.
Yeah, we may need that. Okay. I think we are going to do 2 more questions and then we have to end. So the person, the child was doing both day and night. I think she says she's 6 and she works while she's playing or watching TV.
Exactly.
Yeah.
So that's also one common. So sometimes they have what we call the holding maneuvers. They don't want to go, they are interested in what they are watching or doing. So they would wet. So that some of these children, we also need to put on the bladder diary and assess them fully to make sure that they don't have any other bladder issue with them. Yes. So this child will need to be evaluated.
Okay. And how can they get to see you? So somebody wants to come and see you, Dr. Nyann.
Oh, I'm in University of Ghana Medical Center. So we can. So I'll share a UGMC. I'll share the number with you.
Okay, I think you've given it to me before. Okay, but you share it again. Yeah.
Let me see. No, I think it's not working. I would have even put it.
Let me see if I'll find it.
Mention UGMC. They can call and have a booking. The clinic is on Wednesday. Sorry.
Wednesday. Okay, so I have the OPD UGMC Wednesday. Number. The 020. I can.
Is it Pediatric OPD?
Pediatric OPD, yeah.
Good. 030255.
Yeah.
0849. Yeah. Good. Okay. So when they call, the nurses will book them. Okay. They'll give them a date. Yes.
Okay. Wednesday clinic.
Wednesday clinic booking. Yes.
Okay.
Okay. Someone says they have the number. Yes, it's by appointment. So they can book. So usually, the days I have the enuresis, I don't book a lot because it takes time. It's chatting consultation.
Yeah.
You can spend like 30-40 minutes on one chat. Yeah.
Okay. Excellent. Okay, the last one from the presentation. I think my child has sleep disordered arousal.
Okay.
And she's asking, can having siesta help the sleep disordered arousal?
Arousal.
If they let them sleep during the day, can it help?
So some of these children, that helps. A few of them we might put on something, but usually if you have a well-structured, you have some siesta in the afternoon, they work very hard, they go to bed, they have better sleeps. So that can also help.
Okay.
And then sometimes we actually make them exercise and all, they also helps them fall asleep better. But then if your child doesn't snore or doesn't have any other thing that is also preventing them from sleeping, sometimes even just nasal congestion, especially the younger ones closer to 5 years, it can also disturb them. A few times we do medication. That's one I haven't even mentioned in this, but that can also help. Yes, that can help. Yeah, so that at least they have enough rest in the daytime, and then naturally their body's thermostat will not be high there. Yeah, but we should make sure it's not like they're obstructed. That's why they are not sleeping well, nasal congestion, etc.
Okay.
Yeah.
Okay, so we have to end now.
Hey, technology challenges.
Yes, we have to end now. We recorded the session, so you can check it out on our Facebook page or our YouTube channel. All the questions and those are having answered. The answers are in the presentation, so you can listen to it. And if you can't find the answers there, please contact Dr. Nyann at UGMC, book an appointment to see her and get your child assessed properly, so that so many different things that can cause enuresis, she will not be able to tell you exactly what it is unless she's assessed you. But at least if you watch the presentation again, you can start the behavioral aspects whilst you wait to find her and get your child assessed. Thank you so much, Beatrice. This has been wonderful as usual. Thank you for going through all the stress of the technology challenge and leaving your event to come and give this talk for us. We are so grateful and we appreciate it. Thank you so much.
Thank you very, very much. Thank you very much for having me, despite the challenges.
It was worth the wait. Thank you so much.
Thank you very much. Thank all of you. Bye-bye.
Bye-bye. So thank you guys, all of those who've been able to wait to the very end. We are so sorry for the initial hitch, but I know you really enjoyed the presentation. Godfrey, people are asking for the YouTube channel link and the Facebook channel link. If you are not on our Parents Roundtable WhatsApp group, a link will be posted so you can join. We'll then send you the slides on that WhatsApp group, and we can also send you the links. Next month, we are talking about potty training, and we are also talking about handwriting. So our occupational therapy departments will be taking us on how to improve your child's handwriting and also how to potty train. So do not miss it. If you have friends who you think will benefit from this, please make a date with us. 3rd Saturday next month. We'll send the flyer about a week or so to the time. Thank you very much for spending time with us. We do appreciate your time, and see you next month. Godfred, the link for Parents Roundtable, I haven't seen it all. All I can see is Parents Roundtable on YouTube. Kindly send the link for those who need it, okay? All right. Thank you, everyone, and see you next month. Bye.